the best of hepatology articles in 2017-2018. There were plenty of articles, but because of the time constraint, I restricted the articles which I selected only for these things. In cholestatic group, for biliary atresia, PFIC, paucity, neonatal cholestasis. In infection group, hepatitis C and MLD, I have chosen from NAFLD and Wilson disease. Recently, there were combined guidelines, consensus from NASPGHAN as well as SPGHAN for cholestatic jaundice evaluation in a newborn. And actually, there was nothing much new in this except for that whatever cutoff we were using initially, 20% direct bilirubin to be defined as conjugated hyperbilirubinemia. That thing has now changed, that abnormal conjugated bilirubin is anything more than 1 mg/person. And in addition to this, a new addition is that a modern broad-based next-generation DNA sequencing has been included for differential diagnosis in the recent guidelines. So in biliary atresia, we already know that it is a leading cause of extrahepatic obstructive jaundice, and in absence of surgical treatment, the outcome is poor. Non-visualization of gallbladder during second trimester ultrasound should prompt the concern for biliary atresia. There were new articles in 2015 and 17, and in which it was told that in a prenatal ultrasound, if gallbladder wall is irregular, with a cyst which is visualized in the extrahepatic biliary tract, this should raise a suspicion for cystic biliary atresia. And to differentiate between choledochal cyst and cystic biliary atresia, in the latter, we usually have a normal gallbladder which is larger in size and with associated intrahepatic biliary duct dilatation too. And this prenatal diagnosis will actually help in better parental counseling and management, in the sense that they advise a specialized consult at 2 weeks of age. And at that time, the child was evaluated for cholestatic jaundice, LFTs and ultrasound was done. And if there was any suspicion of biliary atresia, Kasai-Porto-enterostomy was done in these patients, ideally before 40 days. This was one paper in which 35 years of experience from a single center for biliary atresia management was done. And this was a retrospective study between 1981 and 2016. They divided their groups into 2 periods. In period 1, that was from 1981 to 2009, when on suspicion of biliary atresia, a liver biopsy was done, followed by a Kasai-Porto-enterostomy in case it was positive. So there were 230 kids in this, and the mean age of time for surgery was 84 days, and jaundice resolved in 33.5% of the patient. In the subsequent 6 years, there were 27 kids who were enrolled, and there was some change in their protocol. They did ultrasound, and if there was a suspicion of biliary atresia on ultrasound, as well as history-wise and physical examination, they did a primary surgical exploration without a liver biopsy. And once the diagnosis was confirmed, they did a peroperative cholangiogram. They straight away proceeded for surgery in that only. And they found that the mean time of surgery was 66 days, which was significantly less. Jaundice resolved in 55% of patients in comparison to 33.5%, with the survival rate with native liver of 66.7%. So in PFIC group, though it has been discussed in detail in the previous sessions, but I'll just quickly go through it. Previously, only 3 types were known, and partial external biliary diversion was some surgery which was advised to improve the pruritus, reverse growth failure, and arrest disease progression. Recently, there is a paper from SGPGI, and there have been, this is about spectrum of genomic variations in Indian kids, and 9 new major genomic variants have been found in 1/3 of the Indian children with PFIC. There is now a next entity, which is PFIC4, which is because of mutation of tight junction protein. And another entity is PFIC5 is FXR receptor gene mutation, which is the basic purpose of FXR receptor is it's a nuclear receptor which basically balances the production and circulation of bile acid. So if there is problem with this receptor, there is PFIC5 is called, and if there is mutation of NR1H4 mutation, which is a gene which is responsible for FXR receptor, then it leads to complete absence of BSEP expression in biliary canaliculi, which is probably PFIC type 6. Also, there is one paper which has shown that partial external biliary diversion actually does not reduce the need for aggressive fat-soluble vitamins, and there are still recurrent episodes of cholestasis in spite of undergoing this surgery. So this entity still needs to be looked into. As far as treatment is concerned, there was one study in 2015 from a German group who used steroids for 2 cases of PFIC2, and this therapeutic avenue still needs to be studied further. Then there were 2 studies for 4-phenyl butyrate, which has reduced the intractable itching in PFIC1, as well as it has partially restored BSEP expression in PFIC type 2. This recent publication in 2018 has just compared the quality of life of patients with PFIC, whether they underwent transplantation or partial biliary diversion, and they actually found no difference in quality of life as far as itching is concerned. Then bile duct paucity, there was a publication from ILBS recently. They retrospectively checked all the pediatric liver biopsies, which was 632 patients, and out of this, 44 were infants. They divided their patients into 2 groups, destructive and non-destructive type. And what they actually found was that destructive PI-LBD had an odd of poor outcome in relation, just so that they would require more liver transplantation within 1 year of diagnosis. Then in chronic hepatitis C, we have recent consensus guidelines for pediatric patients. Previously, direct-acting antivirals, we all know in adults, they are the drug of choice, and PEG interferon and ribavirin are no more used. But recently, it has been shown that in children more than 12 years of age or more than 35 kg weight, kids with HCV genotype 1, 4, 5, 6, fixed drug combination of SOFU with ledipasvir is the drug of choice. And in genotype 2 and 3, SOFU with ribavirin can be used. And PEG interferon and ribavirin are no more recommended in kids more than 12 years of age. Further, there are studies which are going on in phase 3 trial in more than 6 years of age group also, and in few selected patients, as per a center has to decide, they can still consider using it in kids between 6 to 12 years also. But if any child is coming in less than 6 years, it is advisable that we should tell the parent, give an option that they can wait, because otherwise it's a slow growing process and we have a cure for this disease, so they can wait before giving interferon. For Wilson disease, there is only new recommendation is a Ferenczi score which has come, and previously we were using the cutoffs 40, 100 for urinary copper, but now they say if anything more than 2 times upper limit of normal, or if the 24-hour urinary copper was normal initially, only a 5-time increase from upper limit of normal after challenge is suggestive of Wilson disease. So this is the only change which I found, and they have come out with this new diagnostic score. For fatty liver disease, in 2017 there are recent guidelines, and it has been shown that ALT is the best screening test. It should be at least twice upper limit of normal, which should persist for minimum 3 months to be significant. Use of ultrasound and CT is no more recommended for determination as well as quantification of steatosis. MR can still be used, but it is expensive. Liver biopsy still remains the standard, but it is done only if ALT is more than 80, or there is splenomegaly, or the ratio of AST to ALT is more than 1. And in some high-risk patients who have a positive family history or morbid obese, we can still go for it. There are no currently available medications or supplements as of now. only dietary modification, lifestyle, and in few patients who are really morbid, we can suggest bariatric surgery too. In patients in whom we are potentially going to use hepatotoxic drugs like ATT for any reason, a baseline liver biopsy in a patient with NAFLD should always be done. So there were many other papers, but because the time was less, so I didn't go further, and maybe we'll be discussing in tomorrow and in next sessions about the other diseases. Thank you.